Righto, moving on, onwards and upwards. I now have the pleasure of introducing our opening keynote speaker, Chuah, the Director of the National Health Board Business Unit of the Ministry of Health.
Tihe Maori ora, inga kuia, inga kamatua, tēnā koto, tēnā koto katoa, norera, inga mana, inga reo era rangitirama, tēnā koto katoa. Well, good morning, ladies and gentlemen. Thank you very much for inviting me for your conference. It's a great honor to be your keynote speaker. When I was invited, I wasn't quite sure what my qualification was to actually come and talk at this conference, particularly around what my connections was with rural health. So I had to sort of dive deep in terms of where was my rural connections a little bit. So I have been in New Zealand now for nearly over 30 years, and earlier in my stay in New Zealand, I spent a lot of time in Motueka and Mapua. And actually I was baptized in a very small Anglican church in Mapua, and many summers in Redwoods Valley. And very early in my career, before I started this one, I spent a very interesting week in Geraldine, working for a motor vehicle dealership. And in one of the evenings when there was not a lot to do in a hotel room above the pub, I volunteered to cook for the manager of the garage and had a really great time with the family as well. So I have many fond memories of my connection back with the rural community. These days I live in Wellington. I've been in Wellington for over 10 years now, and prior to that I spent 14 years in Christchurch. And I'm very desk-bound these days, but I look for every opportunity to come out, as it were, out of Wellington to actually sort of meet the real people, if you like. So when I was putting this presentation together, I thought I took some liberties to sort of start really broad and then come back to rural health context. So I'm going to run you a quick, there's only 4 things I want to talk about today. Background, the framework of how I think about how we go about changing things, and a quick rundown of the rural health initiatives. I'm sure many of those will be very familiar to all of you. And lastly, I want to spend a little bit of time talking about implementation and change. So in terms of background, I'm going to do a quick scan of how does the New Zealand health system compare with other countries. There are many stats you can use. I've just chosen to use one. There's no particular reason. And I'm going to show you a graph on health funding, which is sort of reasonably well known now, but I thought we'd just refresh ourselves. A very quick reminder about geography and population, and finish up on challenges and opportunities on this section. So in terms of the health system comparison, this is the, if you look at where the growth in annual health funding across all the OECD countries over the last 10 years in terms of average annual growth. So you can see that I'll point the arrows at New Zealand. New Zealand is still showing an increase in annual funding. What is really interesting is if you look at the countries who are showing a decrease in annual funding, and there are some interesting names down there. Not the least is Norway and Denmark, because in a lot of the discussions we have with international colleagues, often the Scandinavian countries are the ones we look to say they're doing a really good job. And interesting enough, over the last 10 years, I was quite intrigued by actually looking at Denmark and Norway particularly having a decrease in funding. Here's another one, and this one just looks at life expectancy versus the average of spending per capita in US dollars. So you really want to be, you know, at the top, my left-hand corner. So New Zealand's not doing too badly there in terms of where our life expectancy versus health spending. But of course we know that life expectancy is more than just what we do in health. So this is a very famous treasury graph that they gifted to the health sector, always reminding us about how much we spend and how fast the economy is going and how much money they're giving to us in the health sector. And clearly that sort of red curve and the blue curve, and that gap is widening, and that's not a sustainable path going forward. We all know that. So the challenge always is to how do we, well, we're looking at lifting the blue line, and also trying to look at how we bring the red line closer to the blue line. This one, I did this thing. This is really out of the National Health Committee last report on rural health, and they had interesting information there from Stats New Zealand around the concentration of population versus the land area. So you can see that there's a high concentration of a population in a very small land area, and large areas of land with very sparse population concentration. And these are the challenges you all know very well. In terms of challenges and opportunities, some of them are quite generic, others are much more specific to rural health. And the models of care, and what I mean by that, and different people have different interpretation of what that word is. For me, what it speaks to me is about what services is provided, who provides them, where they provide it, and how it's provided. So the challenge there is constantly looking at our models of care and asking whether or not do we need to change, it is still relevant for today's context and today's environment. Funding is always a challenge. I've showed you the curve. But it's not just about the curve, it's actually about how we best use of the funding. Because many of our funding programs are configured for models of care that were suitable 20, 30 years ago, and we haven't changed some of those. The other challenge and opportunity is also about cross-government agencies collaboration. And as I said earlier, I mean, increase in life expectancy is not just about what we do in health. So our social agency colleagues like welfare, education, housing, employment, transport are important cross-agencies that we need to think of how we collaborate with them. Much easier said than done. We can be drawn into lots of meaningless meetings. Workforce, don't need to elaborate too much about that. That's pretty well covered. It's not just about the aging of our workforce, but also about the changing nature of our workforce around different roles, more flexible workforce, people working to the top of their scope. Technology is the theme of your conference. Let's connect it. And technology, like everywhere else in our society, it grows faster than our ability to use them. And one of the challenges in health is that if you look at how we use technology, we are, in many parts of our health sector, well behind what our daily lives in terms of how we use technology. So lots of catch up to do. And I put business and investment model down because that's often one of the things that we don't spend a lot of time thinking about, and yet this is one of those things that stands in our way for change. I haven't put the graph up today, but if you look at where the providers of health services come from, 67% of health services are provided by the private sector. And that includes people like you in the room. And all people in private sectors, you all know, you have your business model, you have your investment model, which are perfectly configured to respond to the funding model and the way you deliver your service. So when we're trying to change something around policies, around different models of care or different funding, we have to think with you quite a lot around the transition and the impact on your business model and investment model. And then particular for the rural community is the geography and the travel issues. I want to talk a little bit about framework, and this helps me, and I'll just move through quite quickly, but this is my way of thinking about how I think about what are the different moving parts that we need to think about when we talk about change in the health sector. But I want to start off by saying that when we look at health and well-being of New Zealanders, it is not just about health services. In fact, some literature say that if we are working to our maximum capacity and capability in health, in some aspects of well-being, we would only contribute about a third. So 2/3 actually comes from all the other components. So we have to think quite hard around that connection between the other social services. But if you look at the health services, integration is the key. And when we talk of integration, we talk really about primary to primary, hospital to hospital, primary to hospital, and they are said between providers and patients and their families. But if you look at health services, the integration challenge there is about thinking about when we want to change models of care, what are the policies and funding and the regulatory framework that has to go along with it? And if we're changing the policy and the funding and regulatory framework, as I said earlier, we actually have to think quite a lot about the impact on business and investment models, particularly for private providers. And of course, all those changes in models of care, strategies and policies on funding and change in regulations, and even if we were able to actually change the business model, is not sustainable if we don't look at the enablers. And in the enablers, we talk about workforce, IT, devices, and infrastructure. In terms of initiatives in the workforce, I've just listed about 10 things there. I'm not going to go through all of them. These are specific for some of them are very specific for rural health. Others are more generic, but has got application to rural health. I'm just going to pick a few and just point them out. I was fortunate enough to actually visit Gore about 15 months ago. And the reason I visited Gore was there was a particularly elderly gentleman who was part of the Grey Power. He was the Grey Power health convener. And before he died, and I didn't really know he was that ill, before he died, he invited me to visit him in Gore, to visit the Gore Health Center. And I didn't manage to get there before he died, but after he died, I made a point of going down to Gore. And in Gore, I saw some of the things that was in there. For example, the mobile surgical bus was there, and I saw quite a lot of the use of different professional groups in terms of how they do things. And the pharmacists were moving in and out of the health center. Workforce New Zealand is part of the National Health Board team, and a lot of the programs here is under their auspices. At their last board meeting, they brought along 4 physician assistants who are working out at Huntly, Kaitaia, Gore, and Hamilton. Now, this is, in some parts of the sector, still quite a controversial workforce initiative. And the interesting thing about the controversy is that when you sit down with those people, those controversies soon seems a long way away. Because when they talk, they're very passionate about working with teams. They're equally passionate about playing a part as part of the team to look after the rural community. About 10 days ago, I also had the opportunity to meet with some diabetes nurse prescribers. And the interesting thing about that was also you see the passion about the new scope that they could carry out. And the interesting thing about that was they were so passionate about what they were doing, they were not aware of the wider debates in the workforce sector around saying, so why did we pick them to become nurse prescribers? What about all the other groups or stuff? So the challenge there was for them to go out and explain to their colleagues around what their role was and what the contribution they were making and the impact they were making for the patients and the partnership they work with doctors in terms of how they work. So as we look at workforce initiative, there is no question that more and more initiatives are going to be looking at not just about recruitment and retention of existing workforce, but also about looking at a different type of workforce. And when we look at different type of workforce, it is always challenging about having the conversation about, is it actually breaking somebody else's rice bowl? And how will it work in a safe way? And how will it actually contribute to a better care for New Zealanders. So this remains a huge opportunity, but also very challenging. But every single one of those different groups that I've met, they are equally passionate about their contribution. So the challenge for us is, how do we create an environment where we can continue not just to have the conversation, but to actually allow progress? In the IT area, I'm not going to go through a lot of these, because I see that on your program, you actually have got Graham Osborne coming to talk to you either today or tomorrow sometime. And Joe, I've just put down the bottom there because I just thought it would be too good an opportunity to miss, just to congratulate you on your success last year in terms of the IT challenge. Telehealth, I've just put down as number 6, but in case you're not aware, the National Health Board IT board has got an IT clinical group. And many of the telehealth projects that I've got in here actually have come out from the group. And the interesting thing about group is that they're a little bit of a secret to themselves. Those who belong to it know a lot of what's going on. Those that don't belong to it know very little about what's going on. And one of the challenges that we've had, and I see that the Minister Rao is going to be here later today. For Minister Rao is that his challenge to many of us is that when you're doing good things, can you think about how you share with your colleagues? Because when the few times when we don't do things well, it seems that it gets a lot of attention, but many of the good things that goes on, not many people know about it. So I think it's quite important for us in the sector to actually think about how we share the many positive things that are actually going on. And telehealth is absolutely one of them. And I've just given you some initiatives that are underway. Some of them are related to funding, some of them related to services. And some of them are work in progress. So number 3 is very much work in progress. There's a level of frustration around how long it's taking to actually do that. But Minister Rao is here later today. You can actually bend his ear on that a little bit. Because but what I can tell you that he is asking officials to pull finger. I want to talk a bit more about implementation. And the reason I want to spend this now, this is the challenge for our sector. It's always about implementation. We spend a lot of time on strategies. We spend a lot of time on plans. We spend a lot of time on working groups. But when it comes to implementation, this seems to be the challenge. And top of mind for me at the moment is that in this sector at the moment, we are going through a huge implementation on the new community pharmacy contracts. And many of the GPs in this room would be aware to greater or less extent about that one. But the implementation challenge there is very significant, like everything else. And there are 4 themes that come up for me when we look at implementation, and I'll put leadership as one. Where implementation has gone well, it is very clear that there is very strong leadership at multiple levels, all right? Not just at the senior level, but at multiple levels. However, if leadership is missing at the most senior level, it is very difficult for people down the chain to actually deliver the implementation. So it's actually beholding on those of us who are holding senior position to provide their leadership, particularly around implementation. Capacity and capability, innovation and change management. So on leadership, I've been, I think quite a lot about this one along leadership because, there are lots of books and seminars on leadership, and I think that we all have to sort of personalize this. So this is a personalization for me of leadership. And the latest book that I've read is, I've given you the book there, is The Leaders We Need. It's written by a Harvard professor. This was written around the time of the first Obama administration. And I've given you the quote on his definition of leadership, which I quite like. because there's some individual words in there that are quite important for me to remember, and I leave that with you. Those who are motivated to achieve the common good, who have the qualities required to gain willing followers in a particular culture at a historical moment when leadership becomes essential to meet the challenges of that time and place. Lots of key words in there. Lots of key words. And I reflect back to those words every time when I face a leadership challenge. And I put those three pictures in there just to sort of jog my memory around the style of leadership that sort of changed over time. You know, when the world was a cottage industry, the style of leadership is very much of a master apprenticeship style leadership. When the world became an industrial era, the leaders that was looked to were the ones that were very good at management, at processes, setting up organizational structures, etc., etc. And they're very process-driven, and they're very hierarchical, and they're very structured. However, those two leadership are significantly challenged today because whilst we still have pockets of cottage industries and industrial era industries, most of our industries are knowledge-based industries. In a knowledge-based industries, the style of leadership is not likely to be a master apprenticeship alone, or an industrial style where it's all about structure and process. So the knowledge-based industry requires much more relationship-based, much more about leaders who are more prepared to hold their ideas loosely, prepared to discuss and agree, to disagree, and think about how they gain followers to achieve a common good, the definition I gave you. And I commend the book to you because it is an interesting read, because after he gives his theory, he gives three scenarios of three industries about the application of leadership. And one, interestingly enough, for New Zealand at this point in time is education. And the second one was in health. And the third one was in politics. So very interesting book to read because it gives you the three sectors. And capacity and capability one, this I struggle with and thought I'd share that with you. And this is still a developing theme in my head. And this particular drawing is nobody's but mine. And I had to draw this to actually help me to understand. Because in the various discourse that I have, I hear the words skills, talent, and knowledge used interchangeably. But they actually mean very different things. And I put this picture together for my reminder, really, to say, you know, when we recruit someone into a role, whatever the role is, whether it's a clinical role, a non-clinical role, there are specific talents of the role that must be matched with the talents of the individual you recruit into the role. That talent, if it's missing, no amount of skill or knowledge can actually bridge the gap. All of us have multiple talents, but there will always be a principal talent. That principal talent has to fit with the principal talent required of the role. Now, however, we have talent, it is not enough. The talent has to be bolstered by actually be given some real skills and knowledge, and the skills has to be developed, the knowledge has to be built, and once that's given, they have to be practiced. And practice can only come about if they're given opportunity, and from that we get experience, from experience we get strength. This is helpful for me. I don't know about you. I struggle quite a lot when I go for meetings, particularly organizational development meetings, where whenever someone said, well, list your talent, skills, and knowledge, I hear all sorts of things coming in. And when I look at good performing teams, it's quite clear to me there are people who are doing really well, that their innate principal talent matches the talent requirement of the role that they've been asked to perform. And they have then had the skills, the knowledge, the practice and experience to actually bring it all to become their real strength. And that's when you see some fantastic performance. I put down adaptive to environment. I put down the word, some of the abbreviation just to jog my memory. I mean, the health sector is complex. It's very fast. It's high volume, right? And the change is constant. So this was actually mentioned to me by a staff member some years ago to say, you know, it's fantastic you send me on this course, but when I come back to work, I'm confronted with all these variables, and the course doesn't prepare me for that, right? So that actually caused me to think quite a lot, is that in the health sector, that is our reality. You know, it's complex, it's fast, it's high volume, change is constant. So the type of people when you're looking for to work and do really well are those who can adapt in that environment. Also, when we look at capacity and capability, various organizations and individuals have different starting points. We are not all at the same starting point. So when we're trying to implement something, we have to recognize people have different starting points. And then, of course, we want to put a team together to implement. Some people are thinkers, or they're very good in strategy, and normally those who are very good with strategies are not implementers, and they are not doers, right? And the doers and the implementers normally are not the big system strategist thinkers. And once upon a time, those two were enough. But today, under a knowledge economy, it is not enough. You need the third one, which is the networker. The networker actually understands the strategies and understands the doers and knows how to bring not just these two people together, but other people together to actually make the implementation work well. But if you look at any implementation, one of the things that often is missing is the governance issues. Time and time again, we will do the form of governance, but not the substance of governance. And when governance is not strong, the people who implement will get lost, and they will make it up. And then is it a surprise then when the project goes astray, we say, well, how come it ended there when we thought we were going there? And that really can only come back to governance. And I put clinical and management capacity capability there because in health, management can't do a thing without clinicians. I'm management, right? A long time ago, some very helpful nurses pointed out to me, you can't do a thing without us. It didn't take me long to learn, by the way. So when I look at DHBs today, some of them are significantly challenged by a lot of things they're doing, and some of them are doing to a range of things. The ones who are making progress have got those elements in there. They engage the clinicians, they are involved in accepting the challenge, they're involved in the thinking of the options that are available, and they take collective responsibility. When management or governance try to do it all by themselves, it is not going to work. But you already know that. Change management. So often when we do implementation, we like to go from A to Z in one step. There's nothing in between. And we often forget about transition or change management. And in change management, all the different things I talked about around business model, investment models, workforce impact, IT impact, infrastructure impact, funding impact, has to be managed through a change process. And it needs very good governance. And the governors have to realize in change management, there are multiple variables that have to be managed, not one. And the devil is always in the detail. If you have everybody who float up at 60,000 feet, you can guarantee it will be a disaster. And there always has to be a program management. Understanding stakeholders and agendas may sound simple, but a lot of people in the change management forget that, or they have a very narrow view around who the stakeholders are. Engagement and communication. Often in change management, most people think about engagement and communication is that we tell you what's going on. There's actually not a two-way conversation. for change management, you need a two-way conversation, and you need it as early as possible. And of course, managing transition and confidence in the process is essential every single step of the way. All right? You can't bring big change if you don't do little things that brings confidence. And again, in change management, we have to recognize not everybody starts at the same point. Innovation. Many of you would have known about this book. If you don't know about a book, can I commend this book to you? Because this book is specifically written for innovative disruption for healthcare. Very interesting author, authored by a Harvard professor with 2 medical doctors. And I put down the motor vehicle industry, retail industry, and the heart industry because this is quoted in the book around disruptive innovations in those industries. And then he draws it into the health industry. And the motor vehicle industry is an interesting one because once upon a time, the US industries was done to by the Japanese car industry. And the Japanese car industry actually came in quite quietly, doing the low-end, no frills, Toyota Corollas, and this sort of stuff. It annoyed the hell out of the US guys, and they actually tried to build their cheap version of that. But after a while, the US motor vehicle industry realized, well, actually, there's no money in this small stuff. We are big listed companies, huge overheads. We need to have vehicles that have huge margins. So messing around with this low-frill stuff is not where we should go. They gave up that sector, that part of their business, and the Japanese car industry took a foothold, and once they took a foothold, they grew from there. The real interesting issue about that is the Japanese never learned about what they did to the US, so now the Koreans are doing to the Japanese. And to think about that one there, it's the same in the retail industry about what happened to the corner store, department stores, and the warehouse. And if you look at the health sector, there is an analogy happening there. And I've used a hospital example around cardiac surgery and interventional cardiology. And these days, we talk about interventional radiology as well. Because once upon a time, if you had a heart problem, you need something done, it was the cardiac surgeon that did it. Well, the cardiologist came along and said, well, actually, we think we can do some stuff. And then the cardiac surgeon said, no, it's not safe. If you want to do any of those interventional cardiology, one of us has to be present. So when interventional cardiology started, a cardiac surgeon actually sat in on the session, but it had nothing to do. So after a while, the cardiac surgeon said, I'm just really wasting my time. I've got other things to do. I can think of more interesting things to do. So they said to the interventional cardiologist, I think it's quite okay for you to do it by yourself. And so they went off to do other things. And just like the Toyota Corollas, the interventional cardiology took a foothold, and they started expanding. Point-of-care testing is another interesting area in health. So the interesting question I have for the rural health practitioners is, what is your equivalent of a disruptive innovation in rural health? And I put those 6 elements in there because those 6 elements are quite important, because when you look at the examples in the motor vehicle industries, the big US companies had these 6 elements in their organization they could not shift and change to adapt to actually combat against the Japanese car industry, because all those 6 elements were perfectly configured for a huge publicly listed organization, and they were not flexible. They could not change. So I just want to conclude by saying we've got enough strategies and plans. I think we all know what to do, and the challenge is about implementation. And when we think about implementation, we need to have a framework, and we also need to be aware that there are many components. And in the end, it is not always about the technology or the technical expertise of people. In the end, I think that what makes implementation work is about leadership, is about capacity, is about capability, and it is always about the people in the room. When I took on this job 3 years ago, I was a bit stressed. And my wife gave these words to me. And she says, it seemed to me that you work in a sector that seems to be in crisis, was the word she used. That must be the way I saw portrayed to her. She said to me, the Chinese word for crisis comprised of two characters. So Wei and Qi. Wei stands for danger, and Qi stands for opportunity. And she says, most of the time, people concentrate on the danger, and they talk up the danger, and ignore the opportunities. I actually shared that with Murray Horn, the chair of the National Health Board, one day, and he said to me, oh, Chai, why does that character, opportunity, has so many strokes? I actually didn't know the answer, but I made it up. I said to Murray, that's because there's always more opportunities in crisis than danger. And I thought I'd finish by giving you back and reminding us a proverb which was given to me by one of the 5 kamatuas that was set aside to look after me when I was a very young chief executive. They have all died bar one, but many of the proverbs that they gave to me remain. So, he aha, te mea nui, he tangata, he tangata, he tangata. Nore ra tēnā koutou, tēnā koutou, tēnā koutou katoa.
Thank you very much, Chai. We have 1 or 2 minutes for perhaps 1 or 2 quick questions, if anybody has got any at this stage. Martin.
Thank you very much for your presentation. A lot of it, sorry, can you hear me now? Thank you very much for your presentation. Of course, a lot of it's very familiar to a lot of us, but it's nice to know we're talking off the same page. I was very interested when you talked about stakeholders and taking them along with you. And I'm always impressed when we are negotiating things, what holds up implementation. And now I'm actually, you've humbled me, because I was going to say, whenever we get stuck in negotiations, I feel I need to ask the question of someone, how could this go wrong for you? Because until I appreciate how it could go wrong for you, and for that matter, how it could go wrong for me, we're not going to get anywhere. Our heads are full of danger. And incidentally, it's the same in a consultation. We make a decision with a patient, and the clinician is thinking, before they make that decision, how could this go wrong? We have to attend to that. But then you put up these wonderful characters, which are so beautiful. And I felt a bit humbled to say, stop focusing on the danger and look on the opportunity, which is great. But I still think it's valid in all our dealings to bear in mind that not everybody has seen those characters, and we have to appreciate from each other, how could this go wrong for you? Because I have to attend to it.
Thank you, Martin. My response to your challenge, Chai, about what can we in the rural sector bring towards to get that foothold and take over? Well, as you well know, as rural generalists, we have an appreciation at the grassroots of what's happening in the health sector. And I see no reason why someone in the rural generalist program can't go on and become CEOs of major hospitals and work their way in, you know, from a grassroots level right up to the top, and something I'd really love.
On that note about CEO, it's a highly overrated profession. As speaking as an ex-CEO. But I think the point Jeremy made is right. It is actually time for primary care, someone from primary care, to actually get into a CEO's role.
Thank you, Chai. Would you please accept this token of our appreciation for coming to join us today? It's nice to see your comments that Tony Ryle has been asked to pull finger. He's obviously taken stock of what Joe presented this morning, so we're already one step ahead of him. Thank you very much.
No, actually, he asked us to pull finger.